Everyone. Myself Anand Hegde. I'm a final year student at King's Hubli and also a core member of White Army. To begin with the case, here is a 6-year-old male child named ABC. He is hailing from Hangal Taluk, Haveri district. He is Hindu by religion. He is accompanied by his mother, who is 35 years old, and she studied till 4th standard. They were admitted on 18 February, and I have examined on 21st February.
All right, very good. Just go back, Anand. Okay, very nice that you've taken the informant and given us details regarding her age and her education as well. In pediatrics, we always would like to know if the informant is reliable. Okay, so that's something you can include. Most often we assume that the mother is reliable, but many times we have the grandmother, the aunt accompanying the child. So reliability of the entire history becomes important. Okay, so that's something you can include at the beginning itself. Okay. Go ahead.
The child was brought with the complaints of fever for 18 days, facial puffiness for 15 days, and generalized swelling for 12 days.
Okay. So that's fine. Go ahead.
History of present illness. The patient was apparently alright 18 days back. Then he developed a fever, which is continuous type, and it is not associated with any chills or rigors. There is no diurnal variation. It relieved on medication.
Okay.
Mother noticed swelling around the eyes and facial puffiness since 15 days. Then it gradually progressed to all over the abdomen and then to legs. The swelling is more in the morning and gradually decreases as the day progresses. There is no pain or redness over the swelling. History of decreased urine output since 10 days is given by the mother. Urine stream is normal and there is no urgency or increased frequency. There is no change in the color of the urine.
Okay, Anand, that's a very briefly put history of presenting illness. So let's analyze this, okay? You nicely described the fever. After all this description, where do you think is the focus of fever over here? Do we know anything by history so far? Where is the focus of fever so far? Do we know anything about where the focus is? We don't know yet, right? We don't know what this fever of 18 days is actually due to. Okay. So what I would suggest is, okay, I'm not too sure if you're going to put up that in the negative history, but whenever you have fever, you very clearly mentioned not associated with chills and rigors. In pediatrics, we are also interested to know whether there's any rashes with the fever. Okay. So a negative history of rashes to be included here, right here, would make a lot of sense. Also associated symptoms of whether the child is having any cough, cold, vomiting, diarrhea, because you really want to figure out if there's an upper respiratory infection, if there's a pneumonia, if there's a gastroenteritis, what's happening there with the fever. Okay, so if you could include these extra points while describing the fever along with your no chills and rigors, no, if you could include rashes, cough, cold, vomiting, diarrhea, all that there itself, it becomes can you hear me now? Somebody is saying my voice is low. Is it okay?
Yes, ma'am, you're audible.
I'm audible clearly? Okay.
Yes, ma'am, clearly audible.
Okay. All right. So you get it, no? So with the fever, if you could include these other symptoms as well, right there, it would make it more complete. Okay. So as of now, you're not too sure about the focus of the fever. Okay, so let's keep that in mind and address this issue later. Okay. Now, the next complaint you went on to is facial puffiness and swelling around the eyes. Okay, you very nicely described it about its progression. Can I ask you why you asked for no pain and redness specifically?
Ma'am, any trauma or any inflammatory cause could be a swelling, ma'am.
Okay, but the thing is, it would not, if any traumatic or any trauma would have, I think, come as the chief complaint itself. Okay, so nobody would really hide a history of trauma. The other thing is, it's very unlikely that a progressive swelling like this will have pain or redness or something like that. Okay, so I don't really think that history was very much required, no pain or redness. All right. And the history of decreased urine output since 10 days is fine. Urine stream is normal. Okay. There's no urgency or increased frequency. Again, I think urgency, increased frequency is may not be required here. Okay, because somebody with reduced urine output may not really present with symptoms of urgency and increased frequency. So you can take that off from here. And no change in color of urine. What specific thing did you ask her?
Ma'am, the color of urine could be red, like cola colored urine is seen in nephritic syndrome.
Correct. Okay. So no red urine. You can specify that. Okay. Specifically, any other change in color you were interested in? Hello? Anand? Hello?
No, ma'am.
Okay. So let me tell you, along with red urine, I think a concentrated urine is something else, something that you would ask for in these children, because you're saying reduced urine output, no? So no change in the color of urine would mean red urine, and the other thing would be passing high colored urine, okay, which may be a sign of concentrated urine. The third thing is children with nephrotic syndrome will often have frothy urine. Okay, so in older children, it's very likely that the mother would have noticed that when the child passes urine, there may be some frothing. So with all this, I think frothy urine is something you should again ask for. Okay. Fine. So move ahead. Okay, move ahead.
Coming to the negative history, there is no history of any palpitations, orthopnea, or dyspnea. There is no history of prolonged intake of steroids. There is no history of loss of appetite, loss of weight, skin changes, and irritability. There is no history of yellowish discoloration or itching of the skin. There is no history of insect bite or any allergic reactions. No history of any nephrotoxic drug intakes. There is no history of any abdominal pain. There is no history of blurring of vision, giddiness, headache, syncopal attack. There is no history of any bone deformity or symptoms of any anemia.
Okay, so let's stop here and revisit this entire thing. Again, just to remind all of you, history should be in the words of the patient or here in the words of the informant. So can you rephrase that palpitations, orthopnea, and dyspnea for me? Anand, you can hear me?
Hello?
Hello, can you hear me?
Yes, ma'am.
Yeah, so I was saying that the history should be in the words of the patient or here in the words of the informant, correct? No? Yes, correct. So you should rephrase the palpitations, orthopnea, and dyspnea. You cannot put those words there. Okay?
Okay, ma'am.
So
palpitation is awareness of his own heart rate.
Yeah, so a 6-year-old boy may be able to tell you that, no, that he can feel his own heart rate. A 6-year-old boy will be able to. If it's younger, again, when the mother holds the baby close to herself, she may feel that his heart is beating very fast. And orthopnea would be?
Orthopnea is breathlessness while sleeping, while on lying
down. Okay. And dyspnea would be?
Difficulty in breathing.
Correct, difficulty in breathing. So you ask these symptoms to?
Rule out the cardiac cause of edema.
Okay, fine, that's all right. So we'll come back to this prolonged history of steroids a little later. Okay, next one is loss of appetite, loss of weight, skin changes, irritability. Why did you ask that?
Ma'am, this could be a kwashiorkor, ma'am. In kwashiorkor also there could be edema. So malnutrition. To rule out a malnutrition as a cause of edema.
Correct. But with all this, I would like to also include their mental apathy. Okay, whether the child is dull. So if you can include that also in the same sentence, no? So it would become very clear that you are hinting at kwashiorkor. Okay. The next one is yellowish discoloration or itching. Okay, that you asked in view of?
Hepatic cause of edema.
Okay, so with that, again, you should ask first. So what hepatic causes are you thinking of to cause such severe
hepatic failure, ma'am.
Correct, acute liver failure. Correct. So they will also have vomiting. So vomiting is another complaint that you should put along with that. Okay. Vomiting, abdomen pain, yellowish discoloration of skin, itching. Fine, that makes sense. Now again, this insect bite and allergic reaction, no, the history would be very acute. You would not have a history of edema of 15 days. Correct? And ongoing insect bite would not cause such a prolonged duration of edema. So that's very unlikely, I think. Okay. Next is the nephrotoxic drug intake. Okay, that you asked suspecting what?
Drug might result into the.
You're right. You're right about asking the history. But tell me why you asked.
It might precipitate the nephrotic syndrome.
Not really, not really. But I think what would be more interesting here is if you're thinking of an acute kidney injury, somebody with AKI can also
AKI.
present with this sudden edema. Okay. So, and a worsening AKI might give rise to progressive worsening in edema. So that's okay. So maybe that's AKI. Abdominal pain is fine. And all this blurring of vision, giddiness, headache, syncopal attack is due to
Hypertensive encephalopathy or
okay. Hypertension is fine. Hypertension makes sense.
cortical vein thrombosis.
Okay, fine, fine, all right, which is a complication. Okay, and bone deformity and symptoms of anemia you asked for?
Kidney failure might result into...
That is chronic kidney disease. Okay,
chronic kidney disease.
Correct. So this nephrotoxic drug intake that you've asked for would be AKI and any progressive bone deformities and symptoms of anemia. So you can't put it as symptoms of anemia. What will you put it as?
Fatigability.
Easy fatigability, irritability, again loss of appetite. Okay, so all those will be symptoms of anemia, and this would suggest CKD. Okay, so fine. So that's a well taken negative history. The only thing is this history of prolonged intake of steroids. Why did you specifically ask for it?
Ma'am, Cushingoid symptoms, Cushingoid disease could result into edema.
Okay, it would not really be like your visible edema. They will just be very chubby. And by just looking at them, they will appear fat. They will not appear edematous. Okay, fine, fine. Okay, go ahead.
Okay.
That's it. This is your negative history?
Yes, ma'am.
Yeah, okay. So tell me at the end of your HOPI and negative history, what are your thoughts? What are you thinking of?
Ma'am, at the end of my negative history, I have ruled out many other causes of edema, ma'am. So at the end of the history, I would be suspecting a renal pathology, ma'am.
Okay, so there is edema, correct? So there is edema here, which you are attributing it to renal. All right. Okay.
Renal cause, ma'am.
Fine.
And in that renal, the nephritic syndrome is very unlikely, ma'am, because the main feature of cola-colored urine is not present.
Okay.
And it is a massive edema, ma'am.
And what else is not present? See, cola-colored urine, red urine may be there. Some mothers may not be very smart to tell you that, so they might have missed it. Okay, there may have been one episode or two episodes. So what else is not there? You don't have symptoms of hypertension also.
Symptoms.
Correct. There is no symptoms of hypertension. So that again points against your
nephritis.
Correct. But at the same
time,
it
is a massive edema.
Correct. It's a massive edema that maybe by examination we'll be able to make it clear. But at this point, although nephritic syndrome appears unlikely, you should put in negative history. There is no history of skin lesions, pyoderma, or in the preceding 2 to 4. You should mention that. Okay, just to tell the examiner that you've thought of it and it's not there. Okay? Okay, fine. Fine. Fine, go ahead. So it's looking like a renal edema, right? So far?
Coming to the past.
So it's looking like a renal edema, and it's looking more like nephrotic compared to nephritis. Okay, so that's the summary of your HOPI and negative history. Fine, go ahead. Yeah, so somebody wants to repeat the last part. Just a minute, Anand. Yeah, so what I was saying is, although by history it's looking like a nephrotic syndrome, we have to mention the history of absence of any skin lesions, like which is suggestive of pyoderma or sore throat in the preceding 2 to 4 weeks. You should mention that in your negative history. All right.
Okay.
Okay, fine. Go ahead. Somebody asked me a doubt about it. Okay, go ahead.
Coming to the past history of the patient, he had a history of similar complaints in the past. He was admitted at the age of 3 years, which was his first episode, and he was admitted for 20 days, and symptoms reduced completely from given medications. The details of the medications are not known.
Okay, fine. So it's fine here to say, 1 minute, it's fine here to say details are unknown, but you may have to probe into a little more. You can ask the mother whether it was an IV medication or oral medication. She'll be able to tell you that. And the duration of medication, I'm sure most mothers will recall that they had to take it for a long duration. It was not something that they received for 1 or 2 days. Okay? And symptoms reduce completely. You should again say, because what are you suggesting this medication as? What do you think is the medication they must have given?
Steroids, ma'am.
Correct. So most likely steroids. No, so definitely you should probe into the history and ask the mother if it is suggestive of steroids. How will you ask that? How will you ask that?
For how long it was given, and
Okay.
whether after some days it was given for alternative days.
Correct. Very good. Yes. Then.
And
what how do you give it? Before food, after food? How do you give it? How do you give steroids? Before food or after food?
after food. I
Correct.
don't know.
Very good. Yeah, you're right. No, you're right. You're right, Anand. After food. That's good. And how else do you know that it's a steroid? What happens after they take steroids? They gain weight. Correct? They may gain weight after taking this medication. They may become irritable. Yeah, maybe proteinuria decrease. That's a very biochemical thing. What will the mother notice? The mother notices that the edema will go away, but the child will start gaining weight. The child will start looking chubby. The child hunger increases. The child wakes up in the middle of the night asking for food. So these very subtle toxicities of steroids, if you ask, in your past history, you may be able to suggest to the examiner that it's most likely a steroid. That makes your diagnosis more possible. All right.
Okay.
Okay. Fine. So you understood, no? So a little more detail on the past history would really help. Okay. Then the other negative history.
There is no history of any blood transfusion.
No history. Why did you ask this?
Ma'am.
Why did you ask for blood transfusion?
Any complications like of blood transfusion might precipitate a syndrome.
Complications, right? Blood transfusion not really. Okay, so the way you could connect this, no? AKI due to infection. Okay, but not really. See, one thing would be we're not hepatitis. Correct. That would be one thing.
Yeah,
why hepatitis B, which may be acquired via a blood transfusion, could be a secondary cause to nephrotic syndrome. Okay, so that's how you would substantiate blood transfusion. No history of tuberculosis contact. Okay, fine. Why did you ask that?
Ma'am, tuberculosis also a precipitating infection.
No, that's not really why you ask it, because you want to start this child on steroids. No, you don't want to flare up a tuberculosis. Yeah. So you always ask, okay, you always ask for contact with tuberculosis, especially if this is the first episode. If we didn't have this history, you should definitely no history of hepatitis, UTI, infective endocarditis, pregnancy, and surgery.
My voice is
just for completion. Hello, Anand.
Ma'am, your voice is breaking, ma'am. Yeah,
Hello?
now it's fine, ma'am.
Hello, ma'am. Your voice is breaking.
Okay. Now it's okay.
Ma'am, could you please turn off the video, ma'am? That time the network problem.
Okay, sure. Okay, is that okay? Okay.
Yes, ma'am. Now the voice is clear.
Okay,
yes,
fine.
Yes, ma'am.
So we were just discussing his past history. I got blood transfusion, tuberculosis contact we discussed. Hepatitis also can be explained. Anand, can you tell me why you asked for UTI, infective endocarditis, malignancy, and surgery?
Ma'am, all are for the same. Ma'am, infectious cause could be because we are giving him the steroids again and. Hello.
Yes, Anand. You're audible. Continue, Anand.
Hello. Yeah,
infective endocarditis also predisposes to a nephrotic syndrome.
Okay, I mean, not really. You don't have to ask like that. Malignancy, which particular malignancy?
Leukemia and lymphomas.
Which particular one are you looking for here?
Leukemia and lymphomas.
Basically, lymphomas. Okay. And no real reason, no? Okay, lymphomas, not really leukemia, but lymphomas. Okay. Hodgkin's and non-Hodgkin's lymphoma will cause secondary nephrotic syndrome. History of previous surgery not really required to ask over here. I think we missed UTI. Have you asked history of UTI? Hello?
Hello, ma'am.
Hello?
The UTI is for the infectious cause.
Hello? Hello, am I audible?
Yes, ma'am.
Yes, you're audible, ma'am.
Hello?
UTI could be audible, ma'am.
Yeah. So I was saying that the history of previous surgery may not be required. Why are you asking for UTI?
Ma'am, urinary tract infection is might be a precipitating factor for.
Hello? Fine, I can hear the piano in the background. All right. Hello?
Yes, ma'am. It's audible, ma'am.
Hello?
Hello, ma'am. Audible.
Ma'am, you're audible, ma'am.
Hello, ma'am.
Hello? Am I audible?
Yes, ma'am. You're audible, ma'am. Hello, ma'am. Ma'am, please on your mic.
Okay, fine.
Yeah, ma'am.
Audible?
Yes, ma'am.
Yeah, audible. Okay, fine. Okay. So we were discussing past history and the history of blood transfusion. He has asked. Somebody has asked me to repeat that. So no history of blood transfusion because blood transfusion is a means to acquire hepatitis B, which can predispose to secondary nephrotic syndrome. And no history of contact with tuberculosis because you intend to start this child on steroids if it's looking like nephrotic syndrome and you don't want a tuberculosis flare. Hepatitis again would be due to the same reason. Infective endocarditis not really required to malignancy, specifically lymphoma, can be another cause for secondary nephrotic syndrome. Again, previous surgery. Anand, why have you asked for previous surgery?
Ma'am, as a routine customer.
Hello, Anand.
Like for hello.
Okay, not really required. Okay. Yeah, not really required. You don't have to include that. Okay. You don't have to include that. All right.
Yes, ma'am.
Okay, fine. Go ahead. Yeah.
Coming to the family history, the child was born to a non-consanguineous married couple for which they have married for 14 years. There is no similar complaints in the family members.
Okay.
This is the family chart.
Okay. Okay, fine. All right.
Shall I go?
Yeah. No similar complaints in the family members. Okay, fine. Then
birth history, antenatal history. There was a regular antenatal visits. Iron folic acids were taken regularly. There is no history of any oligohydramnios. Anomaly scan was done and it was normal. Natal history.
Why have you asked for oligohydramnios in specific here? Why have you asked for oligohydramnios specifically?
Ma'am, usually in the renal problems, oligohydramnios will be associated.
Yes, okay, but not renal problems such as nephrotic syndrome. Okay, there will be oligohydramnios is usually associated with renal developmental abnormalities. Like if you're thinking of a renal bilateral renal agenesis, or anything that fits into the term called CACUT. What is CACUT? You all know it's there in your OP guide. What is CACUT? It's called congenital anomalies of the kidney and urinary tract. Okay. So in CACUT only oligohydramnios will make some significance. Otherwise, nephrotic syndrome per se will not have history of oligohydramnios. All right. Okay, somebody's asked me to repeat. So I was saying that oligohydramnios will be associated only with CACUT, that is congenital anomaly of the kidney and urinary tract, and not in nephrotic syndrome per se. Okay, fine. Yes, go ahead, Anand.
Coming to the natal history, the baby was born normal vaginal delivery with a birth weight of 2.7 kg. The baby cried immediately after the birth. There is no history of any umbilical cord catheterization, no NICU admissions, and there is no complications.
Okay, substantiate why you asked umbilical cord catheterization.
Ma'am, it can cause renal artery thrombosis.
Okay, but a renal artery thrombosis will not present to you sudden, catheterization done in the newborn period will not present to you with renal artery thrombosis so late, and renal artery thrombosis will not at all manifest like this. Okay, renal artery thrombosis manifests with symptoms of hypertension. Okay, so it will not come like this. So again, that may not be very significant in asking here. Okay, go ahead. No NICU.
Coming to the postnatal history, the baby was exclusively breastfed for 6 months.
Just a quick thing here. In pediatric, you don't call it postnatal history. Okay, we call it neonatal history. Postnatal is for the mother. Okay, she's delivered the baby, so she's postnatal, and you learn to make that habit to call it neonatal history. Okay, it's antenatal, natal, and neonatal history. All right. Okay, fine. Okay. Go ahead. Okay, go ahead.
The baby was exclusively breastfed for 6 months, and breastfeeding continued for 1 year.
Okay.
The complementary food started from 6 months onwards.
Okay, very good. Okay.
Coming to the developmental history, the gross motor, the now child can run, he can walk upstairs and downstairs, he can do skipping. Fine motor, he can tie the shoelace and he can draw the triangle and cross sign and even the gate. Social milestone, he can follow 3-step command. Language milestone, he can remember the names and colors. Developmental milestones are appropriate for the age.
Okay, so in a child with nephrotic syndrome, do you expect some form of development to be delayed? If yes, which aspect of this?
Ma'am, growth retardation could be seen, ma'am.
Okay, that's
chronic renal failure.
Okay, chronic renal failure is okay. The other thing in nephrotic syndrome? See, in nephrotic syndrome, especially, okay, let me tell you, in nephrotic syndrome, especially if they are the type of steroid dependent and steroid resistant, they will be on steroids for a long duration. So such prolonged steroids will cause proximal muscle weakness, no? So some of your gross motor milestones, the way in which it's being attained may be a little slowed down. That is one thing. Secondly, you have a number of genetic forms of nephrotic syndrome. So in those conditions, the mental milestones may also be delayed. Okay.
Okay.
Fine. Go ahead.
Thank you.
Yeah.
So, coming to the immunization history, he is immunized up to date. The last vaccine given was DPT booster.
Okay, 1 minute. When it comes to immunization history, no, especially in your exam case presentation, try to avoid saying immunized up to date. You begin by saying what all the child has received up to date. Go ahead and rattle out your immunization schedule, because it gives an impression to show that you know the immunization schedule. So don't just say immunized up to date and finish off. Okay. So what all vaccines do you expect a 6-year-old to have received by now?
Ma'am, from the beginning.
What all do you expect a 6-year-old child to have received by now?
Ma'am, BCG, at birth BCG, OPD. Hello?
Hello?
At birth?
Yeah, correct. So you say, okay, when you are saying the immunization history, you say the child has received OPV, BCG, hepatitis B at birth, and 6, 10, 14 weeks. So you say the entire thing and don't just leave it. Yeah? Okay.
Okay.
And hepatitis B, okay. Okay, then 6, 10, 14 weeks,
6,
1.5
10,
years,
14.
5 years. Fine. So how is this 6, 10, 14 weeks, 9 months, 1.5 years, and 5 years? Okay. So you make it a point to elaborate that immunization history. Now, how is this immunization schedule different for a child with nephrotic syndrome who is on treatment with steroids? So you have a child who
Some
has
extra
nephrotic
vaccines
syndrome.
might be required.
Correct. Some extra vaccines may be required.
Some extra vaccines like pneumococcal, meningococcal, Haemophilus influenza.
Okay. So specifically, at least pneumococcal we have to give. Okay. And what do you avoid? What do you avoid when the child is on steroids? You should avoid all live vaccines. Okay. All live vaccines should be avoided when the child is on steroids. So what are the live vaccines? Can you tell me? OPV. OPV, measles, varicella. Okay. So specifically, you should, whenever you're advising the mother of a child with nephrotic syndrome, you should tell her that when the child is on steroids, these are the vaccines that should not be given. Okay. All right, fine. Go ahead. Diet history. Okay.
Coming to the diet history, the child consumes like 24-hour requirement.
All right. Okay, fine.
The
so
child consumes a diet.
In calories and 24. Okay, fine. Go ahead.
Coming to the socioeconomic status of the child belongs to class 4 socioeconomic status according to modified Basic Prasad. The father occupation is a farmer and he studied till SSLC. They live in a kacha house, but there is no overcrowding and but good ventilation is present.
Okay.
Water supply from well, and it is they drink filtered water.
Okay.
There is no nearby drainage and they use dustbins.
All right. Okay. So why is socioeconomic status important in this child? Why should you ask for all this?
Ma'am, first of all, they will be in steroid therapy and all, ma'am.
Correct.
So, a minor infection.
Okay, that's one thing. All right. Then?
And the diet, ma'am. The diet might not be sufficient.
In proteins. Okay. Then? Plus, I think, nephrotic syndrome is a very chronic disorder. Okay. So, knowing the education, the occupation of the parents is extremely important because you will need them to understand the disease and to, compliance to therapy and whether they'll follow up with you also becomes very important. Okay. Somebody has asked me to explain the diet in nephrotic syndrome. I think we'll do that when we reach management. Okay. I will tell you that. Fine. Go ahead.
Yes. To summarize the history, ma'am.
Okay.
Here is a 6-year-old male child belonging to class 4 socioeconomic status who consumes a diet which is 12% deficient in calories and 24% deficient in protein. Is immunized till date with a normal birth history and family history with a significant past history of similar complaints. Came with a chief complaint of fever for 18 days, puffiness of face for 15 days, and generalized swelling for 12 days, and history of decreased urine output for 10 days.
Okay, so fine. At the end of your history, what is your provisional diagnosis?
My provisional diagnosis could be a renal pathology, most likely to be a nephrotic syndrome.
Okay, you want to add anything else to that?
Ma'am, probably it is a primary nephrotic syndrome.
Okay, maybe.
As it gives infrequent relapse.
Okay, so I think what you should specifically say here is, in view of the previous history where he had responded to steroids, it looks like a steroid-sensitive nephrotic syndrome. Okay, steroid-sensitive nephrotic syndrome is something that you should specifically say over here. And then we don't really know what that fever is all about that you've been mentioning, okay, for 18 days. So we'll see if the examination picks up something. So at the end of your history, my provisional diagnosis would be, it's most likely a renal cause for edema, most likely a steroid-sensitive nephrotic syndrome. with some underlying infection, which hasn't been very clear by history, but we'll see if we can figure that out on examination. Okay? If you say this much is sufficient. Fine, go ahead.
Coming to the examination of the child,
okay,
on general survey, here is a young male child who is conscious, is cooperative, and is also well oriented to time, place, and person.
Okay.
Coming to his vital signs.
I don't think the young really is required there. You can say a 6-year-old male child. Young male child doesn't, not nice. Okay, 6-year-old male child, that's fine. Fine, go ahead.
Coming to his vital signs, his temperature was 98 degree Fahrenheit. It was measured in axilla.
All right.
His pulse was 92 beats per minute. It is
normal for age. Okay, especially in pediatrics, you should say whether all your vitals are appropriate for age or not. Because no, the pulse, the respiratory rate, blood pressure, everything varies across the age. So it's not sufficient if you just give a value. You should also say if it is normal or abnormal. Okay.
Yes, ma'am.
Fine. So temperature is fine. Next pulse.
Pulse rate is 92 beats per minute. It is measured in right radial artery. It is of normal volume. It is non-collapsing, and it is appropriate for the age. Respiratory rate is 27 cycles per minute. It is abdominal thoracic. It is appropriate for age. Blood pressure is 110/70 mmHg.
Okay. Which is?
Appropriate for age.
Appropriate for age in blood pressure in children means what? Okay. See, let's just, telling you all about the vital signs. First thing is now pulse. Okay, that may be really difficult to examine in a child with nephrotic because they have so much edema, no? So really palpating the pulse sometimes may be very difficult. So in children, what we prefer to look at is your capillary refill time. Okay, so in your vitals, you should include your CFT or CRT and say that it is less than 3 seconds. Okay, so that becomes important, more important than the pulse in children with nephrotic specifically. Okay, and respiratory rate, I have one small advice. Don't use cycles per minute. Please say breaths per minute. Okay, so cycles is not appropriate. So 27 breaths per minute. And blood pressure in children, we always have blood pressure centiles. Okay, so we have less than 50th centile, 50th to 90th, 90th to 95th, and 95th to 99th, and more than 99. So anything that is more than 95th centile for age of the child, we call it hypertension. We have charts on which you're supposed to plot and say if the blood pressure is normal or not. So normal blood pressure means it lies between the 50th to the 90th centile for age. Okay. So again, if you all have access to the chart, you should that's something you all should look at and say that it's normal. It's extremely important in this child because hypertension is one thing that puts you more towards nephrotic than nephritis. Okay, so that becomes important. You all understood, no?
Yes, ma'am.
Okay, fine. Go ahead.
Coming to the head-to-toe examination, the child's hair appears to be normal. In the face, puffiness of face was present, but there is no any dysmorphic features.
Okay.
Eye, the pallor was present. Icterus is not present. Sorry, no, pallor and icterus are not present.
All right. Okay.
There is a periorbital edema.
Okay.
There is no features of any cataract of ophthalmos or aniridia.
Okay, fine, good. Then?
Coming to the oral cavity, oral hygiene was good, ma'am. Tonsillitis is not present.
Okay.
And there is no features of any anemia.
Okay. In the oral cavity, another thing that you can include is the presence or absence of oral candidiasis because these children will be on long-term steroids, no? So candidiasis is something that you can include in the oral cavity. Okay.
Okay.
Fine. Then go ahead.
Neck and chest appears to be normal. Skin is normal, ma'am. Nails are normal.
Okay. Fine.
Spine appears to be normal.
Somebody has asked you why have you asked specifically for cataract and ophthalmos. Can you tell them?
Yes, ma'am. There is a syndrome called as oculocerebrorenal syndrome, ma'am, which usually presents with the ophthalmos, cataract, intellectual disabilities, and aminoaciduria, ma'am. And it is also called as Lewis syndrome.
See, one thing is, again, I think you would first like to say that you put cataract because you wanted to rule it out as a steroid effect, no? So you say that first. That is more common because this child is nephrotic. He's been on steroids. So you put that first. And of course, secondly would be to rule out any, I told you there are many genetic syndromes that could be associated with nephrotic syndrome, and hence Anand has very rightly asked for dysmorphic features and aniridia and ophthalmos and all that. Okay. However, Loeys syndrome will not present like nephrotic. That also you should keep in your mind. Okay.
Okay.
Fine. Okay. Spine is normal. Okay.
The lower limb, there is a bilateral pitting type of edema on the limbs.
Okay. Fine. Then?
There is no features of any cyanosis, clubbing, or lymphadenopathy.
Okay. Fine. Anything else? In
Nothing.
your head to toe? Okay, fine. Go back. Now in head to toe, I would like to add a few more things. Okay. Now, firstly, this is the pediatric case presentation. Secondly, this is a child who's been on steroids. So your dentition becomes very important to mention here. Okay. So dentition is one thing. The second thing is very obviously when you look at the child's face, no, what do you see? He has something called steroid facies. No, what is that? The picture that you put up, yeah, the Cushingoid features, okay, where he looks so chubby, he has these big cheeks.
Yes,
so you should mention in your head to toe examination that he has steroid facies or he is Cushingoid in appearance. Okay, so that is something you should add. Then, of course, as another side effect of steroid, you should mention about hirsutism also. Okay, so excessive hair on the body, hirsutism is important. Then I think when you mention your lower limbs and you say bilateral pitting pedal edema, no, you should include at this point if there is any pain, any redness over the limbs, because why? What you any discrepancy in the limb girth? Why am I saying all this? Any discrepancy in the limb girth? No, not CKD, because CKD will come with bent bones. Okay, Nidhi, somebody asked me, it comes with like, like your genovalgum. That's how they will present it. Okay, I'm asking for, no, not hemihypertrophy also. I'm asking, it's something very simple. Okay, discrepant limbs, painful to touch, redness,
DVT.
Cellulitis is right, and thrombus is the other one. DVT and cellulitis. Okay. So these two things you should mention on your head to toe examination when you speak of the limb. Another thing I would like to ask you, did this child have scrotal swelling?
Yes, ma'am.
Okay, so that's something you've not mentioned, right, in your head to toe?
Ma'am, I have mentioned it in genital again.
Okay, that's okay. Okay, that's fine if you put it in per abdomen. Fine, we'll discuss it there then. Okay, go ahead. So you got it in head to toe. What else you should mention?
Yes, ma'am.
Okay, of course, if there is a visible ascites or somebody says, you should put it. Yeah, you should put anasarca and ascites. If it's obviously visible, that should be your opening statement. My opening statement would be, here instead of conscious oriented and all, no, here's a 6-year-old boy who appears to have generalized edema. Okay, so if you begin like that, you know the picture that you're already giving. Okay.
Okay.
And again here, Anand, not just lymphadenopathy, kindly include generalized lymphadenopathy whenever you're saying. Okay. Because we're not worried if the child has 1 or 2 lymph nodes somewhere. What we're worried is generalized lymphadenopathy. Okay, fine. Go ahead.
Coming to the babies, anthropometry,
yeah,
ma'am.
Somebody has a doubt. 1 minute. Rakesh has a doubt. Tell me. Okay, he didn't share. Fine, you go ahead. We'll answer that later. Yeah, go ahead.
The anthropometry, ma'am. The weight was 25 kg. It was observed, ma'am. But for this stage, expected was 27 kg. The inference was the weight lies in less than -1 standard deviation.
Okay.
The height was 124 centimeter. Expected was 124 centimeter. It is in normal range.
Okay, so I have a question for you, Anand. This weight was with edema or without edema?
Ma'am, with edema.
With edema, no? So you be very careful when you're plotting anthropometry for children with nephrotic syndrome, because when they come to you, they come with edema. That is not their true weight. Okay. So whatever the weight that they have is with all that edema. So you cannot really plot it as per other children and say whether it's expected or not. So what I would suggest for you to do in the examination is you say that this is the weight with edema. 25 kg is the weight with edema for this child. And if the mother recalls the pre-edema weight, or if the mother has a document of a previous visit with the pre-edema weight, you use that to plot. Okay. So please don't plot weights with edema for anthropometry. All right. So fine. So here you see that the observed weight of 25 kg is less than the expected. So without edema, I'm sure the child weighs much less and is probably low on his weight. And the height also. Why are we worried about height over here?
Chronic renal failure might result into short stitch.
Okay, but more than that, see, in this case, we're sort of at the end of history, you have a diagnosis of nephrotic syndrome. It's looking more like nephrotic than CKD, correct?
Yes, ma'am.
Yeah. So in nephrotic, why are you worried about the height? Correct.
Steroids,
the child is on steroids. No, the child has been on steroids. Steroid is something that predisposes to short stature. Okay. Yes. Fine. Go ahead. So you be very careful with weight on anthropometry. Okay. Be very careful about that.
Yes, ma'am.
Okay. Go ahead.
Coming to the per abdominal examination, on inspection, abdomen is distended uniformly. Umbilicus is central. Corresponding quadrant move equally with respiration.
Okay.
There is no scars, no visible peristalsis or prominent veins. Hernial orifices are normal.
Okay. Over here, I would like to add, when you say umbilicus is central, most often children will come with so much ascites, no? You should also say that it is stretched. You will have a horizontally stretched umbilicus. So, you know what your books describe as your smiling umbilicus, no? Correct. So, you should mention that it's a horizontally stretched. Plus, I think when you have so much ascites, be very careful about movement with respiration. When you have a massive ascites, it may be very difficult to comment on the movement, okay? So with scars, peristalsis again will be very difficult to see on your ascites. Prominent veins is okay. Something else that you should talk about is striae again as a side effect of steroids. Okay. So if they have any striae, and of course you should talk about the presence of any visible abdominal redness. Okay. Because if you have an abdominal wall cellulitis, which is very common in nephrotic syndrome, you will have a particular area that is comparatively more red. Okay, so you should mention no visible abdominal redness, abdominal wall redness.
Okay.
Fine. Palpation?
On palpation, there is no local rise of temperature and tenderness. There is no organomegaly appreciated. On depalpation, same. The liver, spleen, and kidney could not be palpable.
Okay. What technique did you use to palpate the kidney?
Bimanual.
Bimanual, and what are kidneys supposed to be?
Ballotable.
Okay, so you should remember, because they might just ask you when you say kidneys are not palpable. You should say that. Okay, fine. Go ahead.
On percussion, ma'am, shifting dullness is present.
Okay, which implies?
Around there is 500 to 1000 ml.
Fine. Let me imply 1000 ml. Okay. Moderate ascites. Fine. All right.
On auscultation.
Okay.
Normal bowel sounds are heard.
Yeah. So again, you be very careful about making these statements, because when you have such severe ascites, it may be very difficult. Okay, to hear your bowel sounds or see the movement with respiration. Okay, so that becomes difficult. So how to comment on organomegaly with edema? Yes, so he has rightly mentioned, no, you should do a deep palpation. On superficial palpation, you will not be able to identify any organs. On deep palpation, if the ascites is not severe, you may be able to pick up an enlarged liver spleen. Okay, fine. Go ahead. Go ahead, Anand.
Genitourinary examination.
Okay.
External genitalia appears to be normal.
Okay.
Testis is normal descent at normal position.
Okay.
There is a scrotal swelling is seen.
Okay, so very good that you mentioned the scrotal swelling, but you should also mention if there are any ulcers on the scrotum. So when the child has a big scrotal edema, no, and is continuously sitting or lying down, due to pressure, there may be a scrotal ulcer that is developed, or there may be scrotal cellulitis also, okay, which may be seen as redness and some amount of tenderness. So you should mention that yes, scrotal swelling is seen, but there are no ulcers on it, and there is no evidence of cellulitis. Okay, because again, see, we're still stuck with that fever of 18 days history that you've given me. I don't know what is the fever due to. Okay, we've not gotten anything until now. Where is the focus? So this could be a focus of fever, and you should specifically mention that. Okay.
Okay.
All right, go ahead.
Coming to the other system examination.
Okay.
Respiratory system. Normal vesicular breath sounds heard. bilateral equal air entry. There is no any added sounds.
What do you expect in a child with nephrotic syndrome? Fine, this child didn't have it, but what could they have?
Ma'am, hydrothorax could be there, ma'am.
Bilateral pleural effusion, no? Bilateral pleural effusion. Yeah, fine. So that is what. Yeah, crepitations if the child had a pneumonia only. If the child is with the fever history, if you gave me some cough, of course I would have looked for any presence of any added sounds like crepitations. Otherwise, with severe ascites, be very careful to say that there is no pleural effusion, because very often we will have some pleural effusion. Okay. And because it will always be bilateral. In scrotal edema, can we palpate the testes? If it's a mild scrotal edema, you can palpate. Of course, if there's a huge scrotum, it may be difficult. Okay, fine. Go ahead. Yes. CVS is fine.
There is no any raised JVP, no?
Okay.
And S1, S2 sounds are heard. There is no murmurs.
Okay, fine.
CNS examination.
Okay.
Higher mental functions are normal, no? There is no sensory or motor deficits.
All right, fine. Okay.
Coming to the diagnosis now.
Okay, tell me.
It seems
what
to
is
be
the mechanism of
primary
pleural effusion in nephrotic syndrome? Okay. So what is the mechanism of ascites in nephrotic syndrome? Why do you have edema in nephrotic syndrome?
It is due to hypoalbuminemia and as well as due to the renin-angiotensin aldosterone axis.
Correct. So there are two theories to it. Okay. One is your underfill theory and the other one is your overfill theory. One says that there is a lot of albumin or protein that is lost in the urine, as a result of which there is reduction in the plasma oncotic pressure. So there is third phase loss. There is loss of the intravascular volume into the extravascular compartment. That is one aspect that causes edema, and the other thing is your renin-angiotensin aldosterone system that causes sodium retention and water retention. That is your overfill theory. Okay. So these are the two theories that explain edema in nephrotic syndrome. So just like you can have ascites, somebody asked me why pleural effusion, just like you can have fluid in the peritoneal space, you can have fluid in the pleural space also, and that's why it causes edema. So just going back here, you told me that edema is first noticed in the morning and around the eyes. Why is that so?
Ma'am, usually due to the less tissue tension at the periorbital region, ma'am.
Correct. It's because of the loose tissue that is present in around your eyes, and mostly the child is supine when lying down in the night, no? So it sort of settles there, and when they wake up in the morning, you see it as puffy eyes. Okay. Fine. Yes. Okay. Fine. So you got the mechanism, no, of edema in nephrotic syndrome. Okay. Fine. Diagnosis?
I think it is a primary steroid dependent nephrotic syndrome with infrequent relapse, and there is no impending complications.
Okay. So it is not steroid dependent nephrotic syndrome. Why are you calling it steroid dependent nephrotic syndrome? There is a definition, no, for steroid dependent. Does he fit this?
If there is any relapse occurs, two consecutive relapse occurs within 14 days of therapy, or
when on alternate day regimen.
Or on
alternate day regimen. So that is not there in this child, no?
Yes.
So he is not steroid dependent. What I would put his diagnosis is primary steroid sensitive nephrotic syndrome.
Okay, sensitive.
Okay, primary steroid sensitive nephrotic syndrome with infrequent relapse. So infrequent relapsing nephrotic syndrome is right, with no impending complications. Now here, what are the complications of nephrotic syndrome? List it out for me.
Infections is a major complication, ma'am.
Correct. Infection is a major complication, and you have given me such a long history of fever of 18 days. So we don't really know, no? So I don't know if you should say no impending complications with some infection. We don't know what infection is going on. Okay. So we'll keep that in mind. Infection. What are the other complications you know of?
Ma'am, thrombosis, ma'am. Either renal, cortical, or
renal, cortical. Where else can there be
pulmonary?
Thrombosis? Pulmonary, which will be secondary to deep vein. Okay, so 4 places. Thrombosis is at 4 places. renal vein thrombosis, deep vein thrombosis, pulmonary thromboembolism, and cortical venous thrombosis. Okay.
Yes.
And the other thing is you should mention no steroid toxicity also in your diagnosis.
Okay.
Okay. So the diagnosis for me, what I would put is, this is a primary steroid sensitive nephrotic syndrome with infrequent relapse, with infection, which probably requires some investigation. We still don't know by history or by examination what infection he's having, and with no features of steroid toxicity. Okay. So what is primary nephrotic syndrome?
It is a idiopathic nephrotic syndrome, ma'am.
Okay.
It is most common type of nephrotic syndrome.
Okay, see, what is primary nephrotic syndrome means? It is a type of nephrotic syndrome where you don't have any identifiable systemic or extrarenal abnormality. Okay, that is what primary means. Means it is totally related to the kidney only. You don't have any associated systemic or extrarenal manifestations. And most often, this is idiopathic in etiology. Okay, that's how you should put it. What are some secondary causes for nephrotic syndrome?
Ma'am, infections like hepatitis B, C infections.
Okay.
HIV infection.
Okay.
Protozoal
Diabetic nephropathy is a disorder of the adult, more likely. Okay, so don't really put it here. Amyloidosis, I agree.
Yes, ma'am. SLE.
SLE is fine. HSP.
And some hereditary causes like congenital nephrotic syndrome.
Okay, congenital nephrotic syndrome.
Drugs like
Phenolphthalein purpura you should put. That is very common. Okay, HSP you should put.
HSP.
So infections like, let me summarize, infections like hepatitis B, hepatitis C, syphilis, HIV, syphilis, chronic malaria, SLE, HSP, and some drugs. Drugs and some toxins like what?
Gold, penicillamine.
Correct. So those are very infrequently used drugs, but they can cause nephrotic syndrome. Okay, so in your diagnosis, you take off this dependence. Okay?
Okay. Sensitive.
Why are we calling it steroid sensitive? Okay, I think we'll do all the definitions once. He's steroid sensitive because in his previous episode, which was at 3 years, he was given steroid very likely, and he's responded to it so well that he has had his next relapse only at the age of 6 years. So there has been a 3-year gap of being in remission. So definitely he is steroid sensitive. Okay. So I think at this point, we'll do a few definitions, Anand. You can tell me what is remission?
The remission is said to be when. Hello.
What is remission? Yeah, tell me what is remission of
when urine albumin is nil or it could be less than 4 milligram for 3 consecutive days.
Less than 4 mg per
meter square per hour.
Correct, meter square per hour. Specifically, you should say that. Okay. For 3 consecutive early morning.
Sample.
For 3 consecutive early morning samples. Okay. Hello.
Yes, ma'am.
Yeah. So when we have nephrotic syndrome as a whole, we can divide it into 2. Okay. One is steroid sensitive nephrotic syndrome. The other one is steroid resistant. Sensitive meaning they will respond to steroids, and resistant means that they will not respond to steroids. When you have steroid sensitive nephrotic syndrome, we have some important definitions. The first one is remission. Remission means when you treat them with steroids and for 3 consecutive days, their urine albumin remains nil or trace. Or when you do a 24-hour urine protein, it will be less than 4 milligrams per meter square per hour. When you do 3 early morning samples. Okay, that is the definition of remission. Relapse is what?
There will be urine albumin of grade 3, like that is grade 3 or 4 plus.
3 plus or 4 plus, okay.
3 plus or 4 plus for 3 consecutive early morning specimens having been in remission.
Having been in remission previously, Or when you do a 24-hour protein, it will be more than 40 milligrams per meter square per hour. Okay, so that you should tell. Okay. Then, so what is frequent relapse? What you said here, this child is infrequent relapse. So tell us, what is frequent relapse? What do you mean by frequently relapsing nephrotic syndrome?
If there is any 2 or more relapses in initial 6 months, or 4 or more relapses in any 12 months after the first.
Correct. So what is important to understand here is more than 2 relapses in the initial 6 months. Initial, okay, that word is important. From the onset to 6 months, if he has 2 relapses, or if he has 4 or more in any year, then you call them frequently relapsing nephrotic syndrome. Then what is steroid dependent nephrotic syndrome?
Ma'am, if there is any 2 consecutive relapses when on alternative day steroids, or within 14 days of its discontinuation.
Okay. So that will be steroid dependent. So what is the point that is important here? That you should have 2 consecutive such episodes. Okay. Only then you will call it steroid dependent. Okay. Then what is steroid resistance?
Absence of any remission despite therapy with prednisolone at the dose of 2 milligram per kg per day for 4 weeks.
Okay.
And alternative day for next 4 weeks, ma'am.
Okay. So have you understood? So when you put nephrotic syndrome, you can have steroid sensitive or steroid resistant. And under steroid sensitive, you have all your frequent relapsers, infrequent relapsers, steroid dependent, and steroid resistant is a different entity altogether. Okay. So here, this boy is steroid sensitive with infrequent relapses. Have you understood? Is that very clear to you all?
Yes, ma'am.
Yeah, fine. Go ahead.
What?
Go ahead. This is it. This is your diagnosis. And how would you like to investigate this child?
Ma'am, first of all, I'd like to do the urine analysis, ma'am.
Okay.
The urine protein should be checked, ma'am.
Okay.
It can be checked by 2 methods, ma'am.
Now, what do you see on the urine routine? You will see a urine albumin, urine protein that should be more than. In this child, what do you expect? To diagnose nephrotic syndrome, what should be there? You should have a urine albumin that is more than 3 plus or 4 plus. No?
3 plus or 4 plus.
Correct. And a serum albumin which is?
Less than 2.5.
Okay. And a total cholesterol of more than?
220 milligram per deciliter.
200. Okay. So these are the 3 things that you need to make a diagnosis of nephrotic syndrome. And your urine albumin of 3 plus or 4 plus should be on 3 consecutive early morning samples.
Yes.
Okay. So when your urine albumin, serum albumin are not giving you a direct diagnosis, what you should do is establish a 24-hour urinary protein excretion and prove that it is more than 40 mg per meter square per hour. Or there is another thing that you can do, which is called phosphoprotein creatinine ratio. Okay. So you collect a urine sample and you measure the amount of protein and creatinine in that, and you calculate a ratio. If this phosphoprotein creat ratio is more than 2, then again you can diagnose it as nephrotic syndrome. Fine. What else do you want to see on the urine routine? Other than urine albumin, what else do you get?
Benedict's test can be done.
Fine. Why would you want to do that? Why do you want to do Benedict?
Glucose might be present in glucose.
Glucose will not be present. No, in nephrotic syndrome, usually you don't expect glucose to be there. Again, hematuria is something that you should look for. Okay. Although this child doesn't have gross hematuria, he may have some microscopic hematuria, and that may be normal in nephrotic syndrome. But if he has gross hematuria, definitely it doesn't fit your criteria of nephrotic syndrome. So hematuria, you should definitely look for and say if it is present or not. And anything else you want to do? Any other investigation? So you told me you want to do a urine routine to look for proteinuria, hematuria. You'll do a serum albumin. You'll do a total cholesterol. Then what else will you do?
Profile.
Yeah, lipid profile. Lipid you'll do a total cholesterol. Okay. Then anything else you want to do? Urea and creatinine. No, because you've been saying AKI since the beginning. You want to make sure that this child doesn't have any abnormalities in creatinine. So urea and creatinine you have to do. Then, will you do a C3
Yes,
in
ma'am.
him?
Tuberculosis.
Will you do a C3 in him?
Yes, ma'am.
Why would you want to do a C3 in him?
In minimal changes disease.
No, C3 is more useful to diagnose a nephritis. It is not required to diagnose a nephrotic syndrome.
Nephrotic.
Okay. Especially somebody who's steroid sensitive and infrequent relapses. What is his biopsy likely to be? That is likely to be minimal change disease. No.
Minimal change.
MCD. Correct. So in somebody like this, C3 will not be required. In a child whom you're thinking it may be nephritis, or you have a mixed picture on investigations of a nephrotic and nephritic, then you will definitely look for the presence of C3, which will be low in nephritis. Okay. So per se, to diagnose a nephrotic syndrome, you don't have to do C3. Fine. What else you want to do? Any other test you want to do? Somebody was saying, yeah, chest X-ray. Why you want to do a chest X-ray?
Tuberculosis.
Yeah, so you have to rule out, of course, one is pleural effusion to look for, the other one will be more importantly to rule out any underlying tuberculosis focus, okay, which will be proved by a MAN2. So again, you know, on your head-to-toe examination, it will be very nice if you can look at the BCG scar in these children and say that BCG is there, scar is there, okay. So you'll do a MAN2, you'll do a chest X-ray to rule out tuberculosis because you're going to start this child on steroids, okay. So how do you treat a child who has come with nephrotic syndrome? Ultrasound abdomen will not be required in all cases. So that not for diagnosis of nephrotic syndrome. Only when you're thinking of some complications, okay, like SBP or something, then you can do ultrasound. Otherwise, it will not be required. Fine. Fine. How will you treat this child? Urine culture also will not be required. See, if your urine, if there is something to suggest a UTI. Now, one thing you should understand is when protein can leak out in the urine, even some WBCs can leak out in the urine. So, if WBCs less than 5 are present in the urine, you don't really have to worry at all. Only if the child, especially a 6-year-old child, 6-year-old child is old enough to complain of some burning micturition or something like that. If he has a UTI, he will definitely present with burning micturition. Or if you see significant pus cells, plenty of pus cells on urine, then you can order a urine culture. Okay. I think in this child, maybe, especially children with nephrotic syndrome are very immunosuppressed. One, because of their disease per se, because they lose a lot of immunoglobulins and complement factors in their urine. And secondly, because they're on steroids, they will not mount, responses to infection like another child. Okay, they may not manifest it. And fungal infections are very, very common. Okay, fungal infections are extremely common in nephrotic syndrome. So when you have unexplained fever in any child with nephrotic syndrome, you should always rule out a fungal infection. Okay. Fine. How will you treat this child?
Ma'am, first I would like to give them a high protein diet, ma'am. And salt should be restricted.
Okay.
If there is any associated infections, it should be treated, ma'am.
Okay.
And if there is any massive edema, diuretics can be started, ma'am.
Okay, so what is your treatment protocol for edema? What all do you want to do?
Ma'am, diuretics, especially
fluid restriction may not. Okay, fluid restriction is not required in nephrotic syndrome. Okay, because your fluid is all in the extravascular space. It's not really in the intravascular space. So per se, fluid restriction will not be advisable. What you should restrict is actually salt. Okay, because the more salt he takes, the more water he is likely to take, and there is going to be more, water retention. So salt restriction is advisable more than fluid restriction. So salt restriction will help in the control of your edema. Then diuretics. Name some diuretics. What you would like to use in this child?
Furosemide alone could be given, ma'am, or it could be used with aldosterone antagonist like spironolactone.
Spironolactone. Okay. Then anything else that you can use for the edema? Albumin, no? You can give albumin infusions.
Albumin can be.
Albumin infusions is something that you can do whenever the edema is quite severe. Fine. So you'll take care of edema. Then what else will you manage?
Then definitive therapy can be given.
Okay. Definitive therapy would be?
Prednisolone or prednisone, ma'am.
Okay. Okay. Statins, there is no role for statins in nephrotic syndrome, especially steroid sensitive. Okay? Okay, go ahead.
Ma'am, first of all, we will divide it into whether it is a frequent relapse or infrequent relapse, ma'am.
No, tell me first episode. Tell me first episode, how will you treat her?
For the first episode, ma'am, we will give the prednisolone. That is 2 milligram per kg per day. It can be given in a single or divided doses. It should be given for 6 weeks, ma'am.
Correct. With a maximum dose
of 60 milligram.
Correct. That you should specifically tell. Okay. Fine.
Then followed by 1.5 milligram per kg, ma'am. It should be given as a single morning dose, and it should be given for alternative days for 6 weeks. Ma'am.
Okay, that's how you treat the first episode. How will you treat a relapse? With that 1.5 mg per kg maximum dose is what?
40 mg.
40 mg. So you should specify that. Okay. Okay. What happens to a relapse? How will you treat a relapse?
Ma'am, the relapses will occur because of an infection, ma'am.
Okay.
First of all, we will see whether it is a low grade or high grade, ma'am.
What are the common infections that you come across in nephrotic syndrome? Common infections. What will you come across?
Staphylococcus.
No, varicella is very deadly in nephrotic syndrome. You will come across pneumonias. No, commonly you will see pneumonias. You will see skin infections. Okay, so and you'll see peritonitis. Spontaneous bacterial peritonitis is something that you will see. These are the common infections that you come across. And of course, I mentioned to you fungal infection. These are the common infections. Okay, so if there's an infection, you will treat the infection. Fine. Then you treated the infection, still urine albumin is 3+. What you want to do now? You'll give 2 mg per kg per day. Yeah, you tell me. Hello?
Yes, ma'am. The prednisolone should be given 2 milligram per kg per day until the protein is negative, ma'am.
For 3 consecutive days again. Okay, that you should mention.
Yes, okay, then protein is negative for 3 consecutive days, and then we can start the alternate days dose of 1.5 milligram for 4 weeks, ma'am.
Alternate day for 4 weeks. Correct. So that's how you will treat a relapse. So this is how you will treat your infrequent relapses, especially this is how you will treat your infrequent relapses. So for your frequently relapsing and steroid dependent, what is the fear here? The fear in these children is that you're giving them steroid toxicity. Okay, so you don't want to keep giving them this relapse regimen and push them into steroid toxicity. So instead, you'll give them steroid sparing agents. So what steroid sparing agents are you aware of?
Levimazole, cyclophosphamide.
Levimazole is primarily a what drug? Under what category have you learned it in pharmacology?
Immunomodulator.
Okay, it's also an antiparasitic, correct? That's how it was first introduced. Levimazole was initially introduced as an antiparasitic agent. Okay, levimazole. Then what else is there?
Then cyclophosphamide can be given.
Cyclophosphamide, correct.
Mycophenolate mofetil.
Mycophenolate mofetil is good. Then
cyclosporin or tacrolimus.
Cyclosporin or tacrolimus, which belong to the group of calcineurin inhibitors.
Calcineurin.
No, calcineurin inhibitors. Okay. And rituximab. Yes, rituximab is a new drug that we use. Azathioprine is not validated for nephrotic syndrome. We don't use it. Okay. Then fine. So this was your steroid sensitive nephrotic syndrome. So if you have steroid resistant nephrotic syndrome, how will your management differ? So he's resistant to steroids. So will you give him steroids? First question. How have you diagnosed him? You have given him 4-week steroids and you said there's no response because he's not gone into remission. So will you further continue to give him steroids?
Yes, ma'am.
Not really. Okay, so what we do in practice is we don't really give them steroids because they're already resistant to it, and by giving steroids, you're going to give them only more and more toxicity and infections. Instead, you have alternative drugs, your cyclosporin and tacrolimus. Okay, those are the choice of drugs for your steroid-resistant nephrotic syndrome. The other option to give will be your IV cyclophosphamide. But what will you do differently? One thing you will do very differently when it's a steroid-resistant child. What is the one thing that you have to do in him? One thing that you didn't tell me all this while for steroid sensitive. One invasive investigation.
Renal biopsy.
Correct. Renal biopsy you have to do. So when you have a child with steroid sensitive nephrotic syndrome, which may be frequently relapsing, infrequently relapsing, steroid dependent, there is no indication to do a renal biopsy per se. But if you have some child with steroid resistant nephrotic syndrome, you expect a pathology that is very much non-minimal change. Okay. So you want to look at something like an SSGS on biopsy or MPGN on biopsy, which will further tell you that the prognosis of this child is going to be poor. They may eventually go into something called chronic kidney disease. So it's very important to do a biopsy in steroid resistant nephrotic syndrome. When else will you do a biopsy? What are the other indications for biopsy?
Ma'am, if it is a congenital
nephrotic syndrome, which is defined as the onset of nephrotic syndrome less than
12 months.
No, that is infantile nephrotic syndrome. 3 months. 3 months is congenital nephrotic syndrome. Infantile nephrotic syndrome is less than 1 year. And anything less than 1 year, any nephrotic syndrome onset less than 1 year is an indication to do biopsy. Very good. Then what else is there?
If there is any persistent microscopic hematuria,
correct, persistent microscopic hematuria, low C3 levels,
or hypertension.
Presence of hypertension. Then abnormal creatinine. Okay, when a child with nephrotic syndrome has an abnormal creatinine, and of course, when you have a course that fits into SRNS or steroid resistant nephrotic syndrome, you will have to do a biopsy in them. Okay. Then, okay, so your management, you told me about symptomatic management of your edema, infection, all that. Specific management of nephrotic syndrome. What else would you like to include in this?
AC inhibitors.
Huh? Anything else you want to do?
AC inhibitors. AC
inhibitors is again something that we specifically use for SRNS to reduce proteinuria. Fine. Okay. You're steroid resistant, you can write about AC inhibitors. Anything else?
If the cholesterol level is very high, then
it's very rarely used. Okay. In somebody with steroid sensitive nephrotic syndrome, even if your cholesterol is 600, we will definitely not put them on statins. Okay. Statins is again reserved only for a very minute population, especially if they belong to SRNS, not everyone. So not really SRNS, no, as a something very basic, something little more. Nutrition, of course, you should mention. And nutrition, you should specifically talk about protein, how much protein you want to give them. And of course, your salt restriction, and no other restrictions is really advised. Okay. Antibiotics for infection, he's already mentioned. Anand has already told me that. Blood thinning agents, again, not at all required. Not at all required in nephrotic syndrome. Unless they have a obvious DVT, you will not put them on any kind of prophylaxis. How to calculate the amount of protein in nephrotic syndrome? Usually, we say at least 1.5 times of the requirement for the particular age. Okay? So go a little higher and give them a little more protein diet. What you should mention in your treatment, the other aspect will be immunization. Okay? It's very, very important. You write a note on immunization in nephrotic syndrome, especially when you're writing an answer on management in nephrotic syndrome. No, it seems very complete if you can include immunization also, because they have to immunize with optional vaccines like pneumococcal vaccine has to be given, varicella has to be given, then the child is off steroids. Okay. Now, varicella is a live vaccine. I told you it's contraindicated in nephrotic syndrome child with steroids. Once you stop steroids and it has been 4 weeks of stopping, then you have to give them, after 4 weeks of stopping, you will give them varicella. Another thing that you can give them is influenza vaccine, especially if it is during the season and as long as they are off the steroids. Okay, so that's the other thing about immunization. Nutrition, then you should mention about counseling. What will you counsel a parent with nephrotic syndrome?
Ma'am, the parent should be explained about the disease, ma'am, and what is the usual outcome about the disease of the.
Okay, what will you tell them? I'm the parent. You counsel me.
The disease is curable, and but the treatment should be given appropriately, ma'am. Like chronic treatment might be required.
Correct.
and they must be taught about how to examine the urine, like
Correct.
urine
Very good.
protein.
You should tell them how to do urine routine at home. Okay, so when you're counseling them, no, you tell them in very basic language that what is the pathology here in nephrotic syndrome? You have an abnormality in your glomeruli, correct?
Glum.
Glomeruli
Yes.
are simply the filtering units in the kidney. So you tell them that there are multiple filters in the kidney which are abnormal. Okay, you can give the example of your regular Thai filters at home and tell them that the pores of these filters have actually become bigger. In medical terms, what has happened? What is the pathology that happens in nephrotic syndrome? Your
Yes.
glomerular basement membrane becomes
Glomerular.
more porous, correct? So a
More
lot of
porous.
protein is lost in the urine. So you explain that there is protein loss in the urine. Secondly, you should tell them that renal failure is not equivalent to renal failure. It is not renal failure. Okay,
Yes.
and you tell them that it is a disease that keeps coming again and again, in terms that the child will continue to have relapses over and over. It begins normally by around 2 to 8 years of age, and it goes on till about 18, 19 years of age when it goes off on its own. So it's a disease that keeps coming again and again, and they will have to seek treatment for that and have to be very compliant. And most often the treatment is very long duration, no? So explaining
Yes.
compliance also becomes very important. And of course, you should tell them about all the side effects of steroids and other steroid sparing agents that they would expect also. So if you put this counseling part, especially when you're writing an answer paper, no, if you put this there, it's going to really, create a nice impact, especially, I mean, in any, subject for that matter, but especially pediatrics. You should always write a note on counseling, okay, and tell them that you counsel the parents. All right, any dietary restrictions? Not really. Not really,
Salt.
except for salt when they have edema. Okay, if a nephrotic syndrome child doesn't have edema, don't have to restrict salt also. Only when he has edema, you restrict salt. Otherwise, you don't have to restrict that also. Okay?
Yes.
Protein, I already mentioned to you, you should give them a high protein diet, especially at least around 1.5 times of what is required. Okay? Any other doubts? Anything else you all want me to explain? Anything else you want me to do? What is the difference between anasarca? Difference between anasarca and? Anasarca is another term for generalized edema. So there is no real difference there. Okay. Anand, you want me to answer any more questions? Anything else is there?
No, ma'am.
Why past history of UTI? Okay, so what really happens is, may not be for nephrotic syndrome, but repeated episodes of UTI may lead to chronic kidney disease. Okay. So that's why UTI, because repeated episodes of UTI can give rise to CKD, not nephrotic syndrome. Can there be any atypical presentation of nephrotic syndrome? Yes. Nephrotic, nephritic, we call it. Okay. Where a child will look like nephrotic. They will have, generalized edema, but they will also have hematuria. They will also have hypertension. See, a child with nephritis will not have this generalized edema. They have very mild edema compared to your nephrotic. But nephrotics will have very severe edema. So when a nephrotic syndrome child presents with hematuria or hypertension or abnormal creatinine, that is what is called an atypical presentation of nephrotic. Again, nephrotic syndrome is very common in the age group of 2 to 8 years. So when they present less than 1 year, again, you want to call it atypical. Okay. Cushing-Hart feature facies is a feature of steroid toxicity, no doubt. How is lymphoma related to nephrotic syndrome? Because lymphomas can predispose to secondary nephrotic syndrome. Okay. Yeah, loss of immunoglobulins is there, correct. Why not cardiac edema doesn't cause puffiness of face and periorbital edema? Very good question. Can you answer that, Anand? Why cardiac edema doesn't cause puffiness of face and periorbital edema?
Ma'am, the cardiac edema is due to the back pressure in the right ventricle, ma'am. Due to that,
correct.
As the day progresses, the edema is going to increase, ma'am, because the heart is going to work a lot during the daytime.
Correct.
But in the case of renal edema, it is not the case. It is not due to the heart. It is not related to any functions of the heart, ma'am.
Yeah.
So due to the supine position which the baby lies during the night, the fluid is going to collect in the loose tissue of the periorbital region.
Correct. So renal edema is diurnal in the meaning that the child is supine most of the time, and when he wakes up in the morning, it's visible as puffiness of face. Okay. In cardiac edema, it's due to the it is the fatigue of the heart that happens through the day that manifests as a pedal edema or a dependent edema in the evening. Okay. Again, understand that nephrotic syndrome will never lead to pulmonary edema. That's one edema that you will not see in nephrotic syndrome, because pulmonary edema is secondary to intravascular volume expansion. But in nephrotic syndrome, we have an extravascular volume expansion. Okay. So one edema that we do not see in nephrotic syndrome is pulmonary edema. All right. Hodgkin's lymphoma can cause MCD. Yeah, it causes MCD. Cytokine injury to GBM in lymphoma. Fine. I mean, that is your pathogenesis. Till what age does the relapses occur? Mostly if it's a steroid sensitive nephrotic syndrome, it will disappear by about 17, 18 years of age. But if it's a steroid resistant nephrotic syndrome, they have multiple relapses and they will eventually go to chronic kidney disease. Okay. So if it is steroid sensitive, MCD, fewer relapses, usually by 17, 18 years of age, they're off the disease. But if it is steroid resistant, they have multiple relapses and they will go to CKD. Ma'am, furosemide will be given only if pulmonary edema present. See, this I already answered, that there is no pulmonary edema at all in nephrotic syndrome. Okay. There is all that is there is your extravascular volume. It's that ascites, it's a pleural effusion, pedal edema, scrotal edema. Your intravascular volume is actually depleted. Okay, because your plasma oncotic pressure is less, right? So your fluid moves from the intravascular compartment outwards. So your intravascular volume is less, and so nephrotic syndrome will not lead to pulmonary edema. And furosemide is used to treat edema. It is used to generally treat edema in nephrotic syndrome. Okay. If child has tuberculosis, how different would the treatment be? Okay, Anand, you know this?
Don't know, ma'am.
You know this? Okay, fine, I'll tell you. So if you do a MAN2 and that comes positive, how do you confirm tuberculosis? You have to do a gastric lavage and you have to demonstrate it, correct? You should send it for your TB-PCR and demonstrate it. Now, if he comes tuberculosis positive, or if he is just MAN2 positive, but he is asymptomatic for the disease, you will treat him with isoniazid. Okay. If he is MAN2 positive, but he doesn't have tuberculosis, you will treat him with isoniazid for 2 weeks and then start him on steroids. So first 2 weeks, you give him only isoniazid. After that, you start him on steroids. But if he's a proven case of tuberculosis, you give him the entire regimen for the first 2 weeks, that is your HRZDS, and then you move on to steroids. Okay. I hope that person understood. With ATT, matlab you give ATT for the first 2 weeks, and initial 2 weeks, you don't give them steroids. First 2 weeks, you prep them with steroids and then, prep them with ATT and then you give them steroids. Got it? Is GFR normal or decreased? Usually in per se nephrotic syndrome with no other complication, GFR may be normal. Normal. It won't be. It will be decreased only if he has an AKI, either due to volume loss or due to some infection. Otherwise, he will have a normal GFR in nephrotic syndrome. What if they get TB while on steroids? Do we abruptly stop? No, we don't abruptly stop the steroids, but we reduce the steroids. If you're giving them 2 mg per kg daily, we come down to a dose of 0.5 mg per kg daily. Okay, we reduce the dose. We don't stop the steroids. We never stop steroids abruptly. Why? Why do you not stop steroids abruptly? Anand is there? Why do you not stop abruptly?
Rebound.
Rebound what? Yeah, correct. He's answered. Look at the HPA axis suppression. When you've given it for a long duration, your HPA axis is suppressed, and so you always taper steroids. You never take off steroids abruptly. Okay, fine. Anything else? Any other doubt? Repeat the dose of drugs for relapse. Okay, so when you have a relapse, if the relapse is triggered by an infection, you treat the infection. If despite treating the infection, if your urine albumin is still 3+ or 4+, then you give them 2 mg per kg per day of steroids until they go into remission, meaning their urine albumin becomes nil or trace on 3 consecutive early morning specimens, and then you change to 1.5 mg per kg alternate day for a duration of 4 weeks. Okay. Okay. Anything else?
That's all other doubts.
All right. Okay.
Thank you so much for your time, ma'am.
Yeah. Thank you.
Thank you
Good
so much,
job,
ma'am.
Anand.